Tēnā koutou, tēnā koutou, tēnā koutou katoa. No matamata aho, ko Landers te whānau, ko Amanda aho, nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. So yes, thank you for that introduction. I'm going to present a whirlwind tour through my PhD. Just got my results this week, so preparing for my defence, and just thought I would, oh, that colour has not come out correctly, but anyway, hopefully it will work okay. So my research question was this, basically: what is the experience of people with severe COPD, their support people and their health professionals with end-of-life care services? So that was the basis that we spent the last 3.5 years on. And as with most PhDs, we started with a systematic literature review. I didn't think there was going to be that much in the literature, so I was quite surprised to find quite a bit. And 82 studies involving over 2,000 participants. So this was qualitative studies only. So quite a lot of qualitative studies, but unsurprisingly it was the developed world, so those 3 continents there. Mostly, almost half was within the nursing discipline, and again, over half was from the patient's perspective, so that was really interesting. And we actually looked at the quotes, so the participant voices was what we were interested in. And my supervisors, one of them is Professor Suze Pitama, who's the Dean in Christchurch, and she's a qualitative guru. So she gave me 2 very interesting theories for my PhD, both of which took me about 6 months to get my head around. One was this, the actor network theory. So it basically describes connections that link humans, but also non-humans. And it describes how these connections come to be formed, what holds them together and what they produce. And so there's equal agency given to things like advanced care plans as it does to a human being in the network. So it really flattens the network out and takes out the hierarchy, which was really interesting. And so you could see the things that were influencing the network in a much clearer way. So it may reveal some surprising organisational things, such as the role of a certain actor that has much more influence than you're expecting, such as perhaps a receptionist at a GP practice who is having a lot of influence on the network in a way that you wouldn't expect. And the degree and form of mobilisation of the networks and the way they connect determines the success. So this was a really interesting experience for me to have a look at this. And so remember, this is the literature from around the world. So there was only one New Zealand study. Weirdly, it happened to be my one from a few years ago. So 81 studies from across the world. And these were the 11 actors. Actually, it was about 56 actors, but they fell quite naturally into these 11 groups. So you can see there that the patient is not in the centre. And we talked a lot about that and whether that was actually a realistic thing going forward for the health system. Is the patient in the centre, or are they a stakeholder in the network? And so you'll see the different actors there. And we were quite struck by a few missing actors. So these were just not in the literature at all. So there were 3 that I thought of. One was aged residential care. Was not once mentioned in any of the studies as an actor. Neither was older person's health, and neither was any kind of cultural service. So completely missing. Now, when you see the blue arrows, it means that those 2 actors interacted in a 2-way street, so there was connection both ways. But when you see the red arrows, there was only connection one way. And so you'll see that there's a lot of influence on the patient, but not a lot of the patient going back out. And things like the government were almost completely unconnected or disconnected, and social supports was not very well connected, and neither was acute care with secondary care. So, and when I presented this data to the head of our ED very kind of tentatively, hoping he wasn't going to explode in front of me, he looked at me and he said, "Yes, Amanda, we have so much on our plate. We can't look up and connect with our secondary care colleagues." So quite interesting. So what about here in Aotearoa? So we did 7 focus groups and had 74 participants. We had 2 non-Māori, non-Pacifica patient groups. We had 2 health professional groups, 1 hospital-based, 1 community-based. We had 1 Māori group and 1 Pacific group, and interestingly, the patients and support people in those groups wanted their health professionals there. So those groups looked different and were different in many ways. Then we had this group that organically came out through all the community engagement I was doing, a group that were recently bereaved, so had looked after someone with end-stage COPD recently, as in a few months, and they adamantly wanted to be a group. So we added them, and actually they were the most powerful because they were almost a post-critique of the end-of-life care services for people with significant lung disease. I had to stop them at 2 hours, mainly because I had something else I had to be at. They could have gone on all day. They formed their own community almost in front of my eyes. I did very little talking, very little facilitation. It was very amazing to watch. What did they tell us? Well, out of these focus groups, we managed to analyse the data and come up with 3 models of care. One is the care model, which is the delivery of care. One is the systems model, which is how the system delivers care. And one is around equity, or really that policy government level, and the things that are driving inequity in this group. So it's a little bit all over the place. Sorry, my formatting's gone wrong. But so the care model was the way that the people or the participants wanted care delivered. So that's not just patients and support people, that's health professionals as well. And nicely, there were 5 C's and 4 comms: competence, commitment, community, compassion, and collaboration. I can't read that definition because the formatting's. So competence is knowledgeable and proficient with, I'm not sure, can't tell what that definition is. But what people told us was that competence knows about end-stage COPD, is proactive and efficient, communicates the plan, is accurate, knows what to do in a crisis, assesses and reviews, is up to date and culturally aware. So when we talk about competence, the participants felt that this was the definition. Commitment is dedication to and engagement with other individuals and organisations. So commitments make promises. Now, promises are something we probably try to actively avoid in medicine, but this is what people and participants want from us, and our colleagues want from us. They want continuity of care to fulfil duty. Commitment is persistence. It's actually going the extra mile. It can be small things, but it is going the extra mile. It's part of loving someone. It's being reliable and courageous and consistent. Community. Community shares common interests with each other and experiences a sense of belonging with one another. Community understands each other's stories. So much like Sinead's just shared, the SMOs understood each other's stories, the RMOs would have as well. Community puts others first and supports the family culture. It creates social interaction and gives purpose, has knowledge of the illness, the community has knowledge of the illness, crosses boundaries, and community steps into the gaps that the health system leaves. And I think that really stayed with me for quite a long time, having been a community physician most of my life. Compassion is aware of and responds to the suffering and distress of others. So compassion listens and acts beyond the usual, understands, cares deeply for others, takes away burdens, supports and is interested. And really what Sinead talked about in terms of the SMO-RMO relationship is almost this, colleague to colleague. So we show this to each other, we show this to our patients, we show this to our patients' whānau. They show it to each other. And collaboration is a team player and shares responsibility for decision making in healthcare. So collaboration gives seamless care and it's flexible. Those of us who work in palliative care like to describe ourselves as problem solvers. We like to find solutions to things, give ideas, open doors, we know our own limitations, shares control, is respectful of other team players, validates everyone's experiences and encourages others to participate. So that's the care model, and we'll move on to the systems model. So, yeah. So what were the key indicators of systems integration? This was the first theme. So this is what the participants told us they wanted to make the system deliver high quality end-of-life care and COPD. They wanted a navigator. It didn't have to be a health professional. In fact, participants, patients, put their hands up to be navigators. And there's certainly the support groups that I visited and became part of, they were providing a certain amount of health navigation to each other. They wanted a physical space, somewhere that had COPD on it or respiratory clinic on it, because they saw it for other illnesses. So they saw it for diabetes, they saw it for dialysis, but they never saw anything in the community that they knew was their place. They also wanted cultural safety and that they wanted their families included. Communication. What were the key indicators of communication? They wanted information to transfer with them. They got really sick of telling their story over and over and over, thinking that doctors and nurses would know what medications they were on, that they needed their inhalers at 9 o'clock, having to ask for them, delays, waits, you know it, I don't need to tell you. But it's really frustrating sometimes when you continually get asked the same question. But I understand when you go from department to department in the hospital, all different viewpoints, but they just don't communicate. And I really heard that quite a lot from both patients and whānau. There was also this feedback loop from clinicians. When I send a referral, I'd really like to know it arrived in the right place and that that person's been picked up, because then I don't need to worry anymore. It's sort of a closing off of the loop. And there was quite a bit around translation and using my language and not assuming my language as well. Resource design and development, what were the key indicators there? I need things. So there were instances where people had equipment in hospital, but on discharge did not have that equipment, weren't able to access it, or it took too long. I need people. They'd ring up and say, we're going to get somebody, and then nobody comes, and then they ring up again and nobody comes, and then their 6 weeks was up. So this kind of business that goes on, and IT connections connect with one another. They also wanted standardisation. I was a little bit surprised at this from the participants, particularly the patients. They wanted like a trigger or things that popped up when certain milestones were met. So because they were aware that not everyone was getting the same service, particularly the non-Māori, non-Pacifica groups were aware that they were privileged and were getting quite a lot more service than other people. So they thought one way to make it better would be to standardise. And they also wanted opportunities to plan. So they wanted to do advanced care plans. And governance, what are the key indicators for governance? Well, the big one, prioritisation of social determinants. Housing, transport, housing in a place where their networks are, not miles down the road. Double glazing, temperature control, again, not rocket science, but things that perhaps aren't prioritised. Policies that influence health equity that don't work for me. An example is if you were under 65, you couldn't access the same care as someone over 65. Role of evaluation, they wanted you to check, or us to check as health professionals, that initiatives were working. And that weren't just being thrown in there. And quite a few people, the Pacifica group and the Māori group, talked about strategic plans. These were people who were really, thinking and wanted us to know that they wanted a wider viewpoint, which was great. And finally, equity. Policy, social positioning and service delivery. Policy design. And they outlined ways in which current policies and healthcare contracts perpetuate and consistent delivery of services. So they gave us recommendations for change, quite specific things around funding prioritisation. And one of the really interesting things there is give money to the groups that are already doing it. Give money to the groups that understand us, that are engaged with us, that work with us, because they'll get the results. And I see this in many areas of the health system. I thought that was really interesting. Support for ministries to engage meaningfully with each other, talking about MSD, talking about Ministry of Health, Ministry of Social Justice, all sorts of things. They actually wanted those ministries to talk to one another and coordinate. They also wanted an investment in health promotion and visibility. So many participants said, my whānau does not understand the illness. I walk down the street and I cough and I get a filthy look. I get challenged when I have a disability card, when I get out of the car and don't have a mobility aid. So the social stigma, social ignorance really affected these people. Development of a government-endorsed national respiratory strategy. Again, this came up. There is one, but it's the Asthma Society's one, and it's not endorsed by the government. So it's great for the sector, that sector, but not something that can be worked across sectors perhaps. And so that's one thing. And use evidence. System design, almost there. Invest in public transport that they can use. That's acceptable. Support community-based services. Actually, most people wanted their care in the community. In fact, one of the groups I eventually, after about an hour, said to them, you've not mentioned the hospital. And they started laughing and they said, what can they do for me there? Now I know that that's a very simplistic view and there's lots of things that the hospital does, but it was just an interesting perception. Fund respiratory equipment and GP visits appropriately. Fund high quality home care services, very, very tricky in our current climate. And help people build their own social capital, so put them in places where they can build their social networks or be within them, and so in appropriate housing. And finally, service design. A non-judgmental attitude towards people with end-of-life COPD. Incentives for organisations to work with each other. I thought that was really interesting. Sort of a bit of blue sky thinking in ways that we could incentivise that. And increased awareness of respiratory support groups. Those support groups are run by volunteers with COPD. They cost peanuts. And yet so many of the people who attend them said that they were their whānau, that they cared about them. They followed them up if they didn't attend one week. And they got their health navigation, their health promotion, through those groups. They pay like a gold coin donation for the catering, and I just thought this is such an untapped, cost-efficient way to provide care. And services prioritise advanced care and acute care planning. Development of a diverse workforce that's kind of in play. But particularly the Pacifica group thought that there should be mandatory spiritual and cultural competencies, much like IV competencies or other nursing and medical things that we do, maybe every 3 years or something like that. They talked about coming into the acute system with a brown face, no one asking their actual ethnicity, and getting sent the Māori chaplain, where they're actually Samoan or Tongan, and it's not appropriate. So that still goes on currently in my area. And so these are the models of care that our patients want from us, and the models of care that our colleagues want from us. So just a bit of the food for thought. I've been really privileged to be appointed onto the National Palliative Care Steering Group for Te Whatu Ora, and that was so great because I felt like I could represent my participants and their voices and all the work that and thoughts that they've given me. So I feel very privileged to be able to do that. Thanks. Yeah, I think you could do that actor network theory piece on a different, say, heart failure or another group. There may be different actors and different interactions, but I think you're right. I think that goes a long way then to seeing where you need to strengthen the network. We did a lot of work at looking at what strengthened the network and what disrupted it, and kind of exploring that. So you could easily do that with another group. I think there may be some uniqueness in the actors. There'll be some ones that are the same, but that exercise, which can be done reasonably easily, would certainly be a good starting point. But I think, yes, particularly the long-term conditions group, a lot of this would apply. But I don't think there's the same social stigma. Then, they talked about coughing and bringing up sputum in public, and particularly through COVID, the terrible looks and treatment they got. I'm not sure all other groups would have that same treatment. There's a lot more awareness of other groups as well. So this is the sort of silent group, I think. And they literally, every focus group, almost everyone begged for health promotion. Just tell people what I've got, why I've got it, that it's not always smoking, that whole sort of shame. Yeah. So some unique features, but lots that will be similar too, yeah. The answer is yes and yes. So we did have community hospice participants and hospital palliative care participants, yeah, as part of being one of the actors. So the focus groups fell out of the different actors that we found, plus the missing ones. And so I know in my hospital, in Christchurch Hospital, over 50% of the patients on the palliative care service books is non-malignant. So the vast majority are non-malignant, and a lot of them will be COPD, and I certainly see them in the community a lot. So I think there's probably 3 areas we are valuable in end-stage COPD as a palliative care team. One would be symptom management, one would be environment, and one would be future planning. So it's not that they have to stay on our service the whole time. It could be that we actually do those things. They then stabilise and are discharged, and we come back in if needed. So it's a different paradigm to the cancer one, I think. So just about the actor network theory and how that kind of took out the health professional at kind of the top of the pyramid, is that what you mean? Yeah. And how, as a health professional, I can then use some of that in my Te Whatu Ora role. Is that, yeah? Yeah. So the other theory I used, which I didn't mention, is critical theory. So I used actor network theory and critical theory is the social landscape that it all sits within. So it's the political, social landscape. So it was really interesting. It was very flat and very contextualised. And we always tried to stay true to the voices, and my research group would just keep saying, no, that's your voice, Amanda. Go back to the data. So, one of the working parties of the national group is equity. So once that's formed, I'll give them my work, so at least they've got some evidence of something recent. There's also model of care / adult, that's another working group. And so again, I can give them the systems bit, and I mean, that's all I can do. And then I guess I've just got all my learnings in my head, and as things come up in that national group, I'm sort of saying, like, for instance, people really don't like the word vulnerable, which comes up a lot, but I've heard a lot that people don't like that. And actually, people didn't like the word carer. So that's why we changed it to support person. They're like, I don't have carers. What do you mean carers? So they're the things I bring to the national group, the things that I've heard, and all of the times I've sat with a person with COPD and heard their story. Yeah. But I'm sort of representing rural because I cover Queenstown and Gore clinically, research and palliative medicine. So I've kind of got those hats on the national group. Yeah. I guess I was just surprised at the depth of the lived experience knowledge and how they were able to articulate that in such practical ways. Like one of my questions was, if the government was sitting here, what would you tell them? And they really, like, there was just so much, bouncing ideas, and that's the beauty of a focus group. They all kind of, spiral. Probably the one thing I've taken away is the importance of co-design. Like, you hear a lot of that. I think you need both sides of the fence. You need lived experience and you need that sort of systems, clinical coming together. Because really, if we were designing a health system for COPD from scratch, I think it would look quite different, and I think it would cost less. Yeah, so as I said, I work in the community, so I get to go into people's homes, and the power balance is quite different to working in a hospital setting. So it's their space and their place. And you get to see, their environment. They cannot let you in, which is different to a hospital environment. So that's been great. You get a lot of sort of three-dimensional information. You get to see how they walk as they open the door, how they're dressed, how their garden is, are they neglecting things? There's a whole raft of information that you get, and you build up a really great picture. It's much more intimate. You're in their place. We do a lot of, as Sinead said, I say to the medical students, palliative care is the only specialty that has time. We're very lucky, we are privileged, but we couldn't do our job without it. There's just no two ways about that. So, so there's a lot of just sitting with people, holding their issues, negotiating as a team. I say to people, you're the chairman of the board, this is your committee, being your whānau, and let's all kind of negotiate this together. Challenges, I'm not sure if you're aware, but Queenstown fluctuates from about 15,000 to 100,000 depending on the season, and there's a 10-bedded hospital there. So if you're a local that gets sick in tourist season, you're lucky if you can get into your own hospital. District nursing is quite short hours, and trying to then plan a community death is quite tricky, and there's a lot of planning that goes on. We are very spread thinly, lots of solo practitioners in big areas across the country. So just asking me about the hybrid model and how I found that as a clinician. Well, once I had my kind of structure being a systematic literature review, which is easy to publish, as chapter 2, chapter 1 being the introduction, and then methodology paper, which again you put into a methodology journal, and then your results chapters. It does flow reasonably well. It feels like a nice cohesive kind of story, and then you just link it using chapter summaries and chapter introductions so that it kind of flows for the reader. But you don't have to keep repeating. Once you've published your methodology paper, you can just refer to it, so it becomes quite nice that way. So luckily someone gave me kind of an example of one that I could look at, and it really did flow quite nicely. 2 of the papers are published and the other ones are under review. The issue I had was there's no Australasian palliative care journal. So everything has to be international. It took a long time. It was during COVID. No one was reviewing those kinds of challenges. But I think it was quite a nice format.